A 57-year-old man who is an accountant comes to the physician because of progressive shortness of breath during the past 6 months. During the past 6 months, he says that he has difficulty breathing after after waking more than after walking more than one city block, and when walking up of one flight of stairs. He reports that during this episode he feels that he needs to breathe rapidly. He also has a dry cough. He has no chest pain, diaphoresis, nocturnal symptoms, worsening of symptoms when lying down. He has 5-year history of hypertension treated with enalapril hydrochlorothiazide. He has never smoked. His temperature is normal, pulse 89, respiration 18 per minute, blood pressure 145 by 82, pulse oximetry on room air show oxygen saturation 90%. Crackles are heard on both lung bases. High resolution CT scan of the chest show reticulogranular appearance at bases, bilateral with minimal fibrosis. Pulmonary function tests show moderately severe decreased diffusion capacity. Examination of the bronchoscopy lab has shown many segmented neutrophils that are not negative for bacteria, fungi, acid fast bacilli. In addition to supplemental oxygen administration, of which of the following is the most appropriate next?
Ready?
Yes.
It is prednisone. Idiopathic pulmonary fibrosis is a chronic progressive lung disease characterized by scarring of the lung parenchyma. Fibroblasts in the lungs become activated and produce excessive amount of extracellular matrix protein, leading to formation of fibrotic scar tissue. Excess tissue reduces the compound of the lungs and make it harder for them to expand. This leads to decline in overall pulmonary function and restrictive pattern of disease, characterized by decreased total lung capacity. Symptoms of pulmonary fibrosis include shortness of breath, especially with physical activity, dry, hacking cough, fatigue, weight loss. The major risk factor for pulmonary fibrosis are advanced age, smoking, exposure to environmental irritants, though a direct genetic link has not been identified. Pulmonary fibrosis does seem to have hereditary basis. The prognosis of pulmonary fibrosis is really poor. Median survival time from the time of diagnosis is 2 to 5 years. Treatment typically includes oxygen therapy and medications such as steroid and immunomodulators. Not cyclophosphamide is DNA alkylating agent that is used primarily in treatment of various malignancies. It forms cross-link on replicating cell DNA and prevents those cells from further proliferation. Occasionally, it is used for autoimmune disorders such as rheumatoid arthritis, lupus, but not for pulmonary fibrosis. It's not cyclosporine, a monomodulator that acts by inhibiting T lymphocytes. It's used commonly in post-transplant patients to prevent rejection. It may be used in patients with pulmonary fibrosis who undergoes lung transplant, but not as treatment for the primary disease. Mhm.
Next. A 57-year-old man comes to the physician because of severe right shoulder pain. Having generalized tonic-clonic seizure 3 days ago, he has noted the pain. In the emergency department, he was brought after the seizure. He reports no other histories of shoulder pain or injury. He has 40-year history of seizure disorder treated with phenytoin. His only medication is acetaminophen for shoulder pain. On examination, passive and active range of motion of the right shoulder elicit pain. External rotation of the shoulder limits to 10 degree and AP shoulder obtain energy delivery treatment show no abnormality. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
Is lateral X-ray of the right shoulder. Uh, Posterior dislocation of the shoulder can occur after seizure as well as from electricity or an anterior to posterior shoulder trauma. Anterior dislocation make up most shoulder dislocation cases, often occurring during the posterior to anterior blow to the shoulder while in the throwing position. Posterior dislocation of the shoulder occur in cases of seizure, electrocution due to internal shoulder rotators contracting with greater force, and compared with external shoulder rotation. Physical exam may disclose prominent coracoid process with anterior flattening of the shoulder. X-ray should include a lateral view, as an anteroposterior view. X-ray may miss out 50% of posterior shoulder dislocation. Lateral view. Okay.
What is
This,
arthrography?
uh,
The option C.
okay, let me finish. Yeah, let me
Yes, sir.
finish reading. Mhm. Treatment includes close reduction of the shoulder joint. In cases of recurrent dislocation and joint laxity, operative management may be indicated. For this patient, a lateral X-ray of the right shoulder should be obtained to further evaluate shoulder joint alignment in the setting of recent seizure, reduced range of motion, and continuous severe shoulder pain. Arthrography is a diagnostic modality to evaluate joint structure and function, yeah, as well as to identify intra-articular pathologies. In arthrography, intraarticular contrast is injected prior to the imaging study. For this patient, lateral X-ray will be a more appropriate next step to evaluate alignment of the shoulder joint. Okay. Physical therapy yeah, is a reasonable treatment option in the setting of shoulder pain and is often one of the first-line conservative options in management. This patient is presented with severely limited range of motion following a recent seizure. Further imaging should be obtained first to evaluate the shoulder prior to referral to physical therapy. MRI of the shoulder can be used to evaluate the muscles and ligaments of the shoulder. The patient may have underlying or new soft tissue shoulder injury secondary to recent seizure. For this patient, lateral X-ray of the shoulder should first be obtained to further evaluate the shoulder joint alignment. Next,
Yes. A 72-year-old man with hypertension comes to the office because of 7-month history of post-void dribbling and urinary incontinence associated with urgent and unexpected sensation of the need to urinate. His medications are lisinopril and aspirin. His blood pressure is 160 by 80. Examination shows normal external genitalia and moderately enlarged farm process. His PVR is PVR is normal or high? Which of the following is the most likely cause of these restrictions? Okay.
okay, so it is bladder outlet obstruction. BPH affects middle age and elderly male patients occurring because of excess growth tissue in the central prostate, causing a lower urinary tract bladder outlet obstruction. BPH presents with urinary dribbling and incontinence, difficulty starting or maintaining urine stream, nocturia, the need to frequently urinate, and incomplete voiding, such as in this. These symptoms are typically insidious and onset, chronic and progressive. Diagnosis is made with history, physical, and urodynamic testing, along with ruling out alternate diagnosis. Like malignancy, treatment is with supported alpha blockers, 5 alpha reductase inhibitors, and or surgery. Acute complications of prolonged bladder obstruction include bladder rupture, urothelia, cell atrophy or necrosis, hydroureter, hydronephrosis, postrenal azotemia, and kidney injury. Next.
Why it is not detrus or underactivity?
The true underactivity is a characteristic of neurogenic bladder. While neurogenic bladder can also lead to symptoms of overflow incontinence, like this patient presenting symptoms, his symptoms are more likely caused by bladder outlet obstruction with an enlarged prostate. Neurogenic bladder is associated with dementia, diabetes mellitus, strokes, multiple sclerosis, and spinal cord pathologies.
Okay, next. A 37-year-old woman comes to the physician for routine health maintenance examination. She feels well. She has no history of serious illness, no allergies. She takes no medication. On examination, 1.5 centimeter nodule over the right aspect of the thyroid gland is palpated. There is no lymphadenopathy. The remainder of the examination show normal. In addition to measurement of the serum TSH concentration, which of the following is the most appropriate next step in the management?
Ready?
Yes.
Is ultrasound of the thyroid, detection of a palpable thyroid mass by a patient at home or during routine clinical visit is a common occurrence, and the diagnostic work will focus on ruling out malignancy. Risk factors for thyroid malignancy include young age, the prevalence of benign thyroid nodule increases with age, radiation exposure to the head and neck, and a family history of thyroid cancer associated congenital neoplastic syndrome like men too. All patients with a new nodule should be evaluated with serum TSH measurement and thyroid ultrasound. Ultrasound guided fine needle aspiration biopsy can be performed at the same time, which is recommended for patients with risk factors for malignancy or for nodules with concerning features. Subsequent workup and management are dependent upon the result of TSH concentration and ultrasonography characteristics of the nodule and biopsy results. Next.
5 day, 5 days after undergoing abdominal hysterectomy for leiomyoma uteri, a 57-year-old woman is evaluated because of abscess formation and partial dehiscence at the incision site. She is 165 centimeter tall and weight is 73 kg, BMI 27 kg per meter square. She received perioperative prophylaxis with an appropriate antibiotic 90 minutes after the surgical incision was made. Hospital recommendation specifically that patient should receive antibiotic prophylaxis within an hour before the surgical incision is made. After admission to the hospital, patient are transferred to the preoperative holding area 30 to 90 minutes before their operation and then transferred to the operative room for induction of anesthesia. A patient's preoperative antibiotic prophylaxis may be administered by a nurse on administration or in preoperative holding area by anesthesiologist during the induction of the anesthesia. Which of the following is most likely root cause of this error? Ready?
It is a lack of standardized delivery and verification delivery antibiotic. This patient appears to have surgical site infection 5 days after undergoing hysterectomy. Currently, a root cause analysis (RCA) is appropriate to determine the contributing causal factors leading to this adverse event. RCA involves determining the core issue that led to chain reaction of events that culminated in the adverse effect. There are several RCA strategies, including creating a timeline, surveying the controls in place, that may have failed and completing a risk tree analysis where the impact of each event is considered. Regardless of strategy, a typical RCA involves assembling a multidisciplinary team and meeting with this team regularly for a period. This team works to define and analyze the problem and design a set of corrective actions based on the analysis. In this case, hospital policy is that patients should receive antibiotic prepared within 1 hour before the surgical incision. However, this patient received it like 90 minutes after surgical incision was made. It's also noted that this antibiotic can be given preoperatively by a nurse on admission in the preoperative room or by anesthesiology during induction to anesthesia. Based on this, it appears that standardization of the delivery and subsequent verification of the delivery of this antibiotic was not performed prior to surgery. It is not the surgical surgical nursing error in delivering antibiotic is not the root cause of this adverse event. While there was a nursing error in the delivery of antibiotic, the deeper cause and issue is that this lack of delivery was missed at many steps. The lack of standardization of this process is the main concern in this scenario. Creating a standard process will reduce the risk of similar error in the future. Next.
A 57-year-old man comes to the physician for a follow-up examination one day after fasting. Blood glucose shows serum glucose concentration 128. He has no history of serious illness, takes no medication, he has no allergy. He appears comfortable and is not in distress. He is 173 centimeter, 5 feet 8 inch tall, with 111 kg BMI, 37 kg per meter square. His pulse is 82 per minute, blood pressure 130 by 84, cardiopulmonary examination shows no abnormality. Distal pulses are normal, neurologic examination shows no focal finding, which lab studies are most likely show which of the following. Ready?
One moment. Yes, already. Let's see. Type acid now. Increase C peptide concentration. I thought his fasting was fine. Type 2 diabetes metabolic syndrome defined by progressive insulin resistant inflammation and chronic predisposition to hyperglycemia. Initially, as insulin resistance develops, patients will compensate with increased insulin production and thus increase C peptide production. Over time, insulin resistance will continue to increase and eventually result in decreased insulin production as a result of burnout of pancreatic beta cells and their resultant destruction. Type 2 diabetes has a strong familial predisposition and is generally associated with obesity, though it can initially be associated with weight loss as seen in this patient. Weight loss. Okay. It tends to present in patients over the age of 40, in contrast with type 1 diabetes, which predominantly presents in childhood. Treatment of type 2 includes lifestyle modification, oral antibiotic, anti-diabetic medications, and occasionally insulin based on response. Given his age, the most likely diagnosis of this patient is type 2 diabetes, and he will likely have increased serum C-peptide concentration because of increased insulin production. Wait, I saw the fasting glucose, let me see, was normal. Let me see.
Fasting glucose,
Oh, sorry.
it is
I
not
thought
normal.
it's high, it's high. It's high.
Normal blood glucose is 70 to 120, isn't it?
No, normal, non-fasting and random is less than 140, and fasting is 70 to 100.
Fasting is 70 to 100. Non-fasting less than 140.
Mhm.
Okay. Question 7. A 42-year-old man comes to the physician as a new patient. She has hypertension. Well controlled with lisinopril, he has no history of serious illness. He is 178 centimeter tall, weight is 66 kg, BMI 21, blood pressure 120 by 70, cardiopulmonary examination shows no abnormality. The abdomen is soft, non-tender. There is abdomen is soft and non-tender. There are no masses. There is no edema of the extremities. Results of the lab studies include complete blood count are within the reference range. Urine dipstick is positive for blood. Which of the following is the most appropriate next step in the management? Okay, ready?
Okay. It is a microscopic exam of urinary sediment. Glomerulonephritis refers to variety of glomerular disease, including nephritic nephrotic syndrome. Nephritic syndrome typically presents with acute kidney injury associated with hematuria, RBC, CAS, and hypertension. This should be investigated in young patients with history of hypertension. In a patient with urine district positive for blood, urine microscopy should be performed to evaluate for RBC CAS or other signs of glomerulonephritis. In contrast, myoglobinuria and rhabdomyolysis can cause urine district positive for blood due to the presence of myoglobinuria without microscopic evidence of RBC. Therefore, microscopic examination of the urinary sediment should be performed to evaluate for presence of or absence of RBCs. The underlying reason for this patient positive urine district is unclear, confirming whether RBCs are present via microscopy is the best next step in narrowing the differential diagnosis. Additional differential consideration include but are not limited for malignancy and trauma. Next.
Yes. A 57-year-old woman comes to the emergency department because of one-day history of productive cough, a blood-tinged sputum. She notes that since this morning she has coughed up approximately one cough of bright red blood. She has not had fever or chills. She has 4-year history of post-nasal drip, nasal congestion. She has smoked one pack of cigarettes for 40 years. Her blood pressure is 100 per minute, respiration 22 per minute, blood pressure 130 by 80. Pulse oximetry on room air show oxygen saturation 92%, diffuse wheezes are heard. At the left lung base, X-ray chest shows loss of volume in the left hemithorax. Which of the following is the most likely diagnosis? Oh,
Bronchial lesion, chronic bronchitis.
ready?
One moment. Not figure. 4-year history of postnasal drip, nasal congestion. State endobronchial lesion or chronic bronchitis. Diffuse wheezes are held at the left lung basis. Mm, Loss of volume in the left hemithorax. Okay, fine. Just pick one. Okay, ready. Endobronchial lesion. Bronchogenic carcinoma is a leading cause of cancer-related death in the US. It's typically divided into two classifications: small cell or non-cell cancer. Small cell non-cell. Okay. Commonly presents with cough, weight loss, hemoptysis, and potential signs of bronchial obstruction such as wheezing. Bronchogenic carcinoma uh, most commonly occurs in smokers in their fifth, sixth decades of life. Other risk factors include exposure to secondhand smoke, radon, asbestos, and family history of lung cancer. Treatment generally includes surgery, radiation therapy, chemo, and targeted pharmacotherapy. The treatment of choice is dependent on the stage and type of cancer, as well as the patient's ability to tolerate invasive treatment. Okay. Early detection and treatment of paramount as prognosis is that in advanced stage disease has 5 year survival rate or less than 15%. Diagnosis is made via chest X-ray, CT scan, PET scan, and biopsy. Histologic exam is required for definite confirmation. Chronic bronchitis refers to long-term inflammation of the bronchi and is commonly seen in patients who use tobacco. It's defined as presence of a productive cough on most days over a 3 month period for at least 2 consecutive years in patients who do not have another cause of cough. These patient time course and symptoms are inconsistent with chronic bronchitis, 3 months during 2 consecutive years. Okay.
Next,
Mhm.
a 17-year-old girl comes to the office for health counseling 2 days after endocervical swab obtaining during the last pelvic examination was positive for Neisseria gonorrhea by NAT and amplification test. She has had unprotected sexual intercourse with several male partners. One of the partner was IV drug. One of her partner was IV drug user. She refuses HIV testing. She insisted the test result should be kept strictly confidential. Which of the following is the next step? Ready?
Okay. A, inform the patient that her infection has to be reported to the health department. All states in the US have requirement for mandatory reporting of particular STIs to state and local health department. Timely reporting of STIs to appropriate health official is important. In partner notification and reducing the incidence and spread of infection. The national blah 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 maintained by the CDC blah, blah, blah is a national database that allows sharing of case information to all federal, state, and local health departments. While certain states have more stringent reporting requirements for other infections, HIV, syphilis, gonorrhea, chlamydia, and chancroid are mandatory notifiable disease in every state. Other non-STI, non-sexually transmitted infections such as TB, pertussis, and meningococcal are also notifiable in most states. This patient should be informed that her case information will be reported in the health department as mandated by law. It is not report infection to her partners is incorrect. Healthcare providers are required to report notifiable STIs to appropriate state and local health departments. Notification of partners may or may not be conducted by state or local health officials according to applicable guidelines. New states have requirements for physicians to notify sexual. Few states have requirements for physicians to notify sexual partners. As always, physicians should be familiar with applicable. So, okay. Respect the patient confidentiality. Report the infection to no one is incorrect. Failure to report the mandatory reportable infection is illegal. Failure to report or delay in reporting such infections may result in fines or imprisonment, depending on federal patient privacy laws such as health HIPAA allow exceptions for disclosures for mandatory reportable infection illnesses.
Okay, ready?
Uh-huh.
An 8-year-old girl with myelomeningocele. An 8-year-old girl with myelomeningocele is brought to the physician by her mother. By her mother prior to prior to transitioning from a special needs school to a public school. The patient uses wheelchair. She is trained self-authorization. Our only medication are prophylactic antibiotic prevent UTI, muscle strength 1 by 5 on hip flexion and adduction bilaterally. Our mother is concerned about how best to maintain her daughter's health in the new school. She notes that her daughter had a physical therapist and an occupational therapist in the classroom. In the special needs school, which of the following is the most appropriate? Ready?
Mhm. Train the patient to habitually change body position to alter areas of pressure. Because this patient is at risk for pressure injury or ulceration, it's best to train the patient to habitually change the body position to alter areas of pressure. Pressure injuries represent areas of tissue damage, commonly over bony prominences because of pressure ensuring forces. Clinical evaluation of pressure injury shows finding raising findings ranging from initial non-branchable erythema, warm and in duration to deep alteration. Prevention of pressure injuries includes frequent changes in position and avoidance of moist environment. Once a pressure injury has developed, strategies to offload pressure are used to promote wound healing in addition to pain control, wound care, treatment of secondary infection, and optimal nutrition. Given this patient wheelchair dependence, frequent repositioning represents the best intervention to maintain her health. As the school to equip the patient classroom with latest gloves may be necessary but does not represent the best intervention for this patient. Gloves are necessary for medical exams, procedures where there is concern for pathogen spread by contact, transmission, or from whatever. The patient should be provided gloves as needed for self-catheterization. Regardless, patients with chronic ulcerations are at higher risk for secondary infection, which may be prevented by frequent repositioning. Next.
A 27-year-old woman comes to the physician because of 3 week history of severe rectal pain with defecation. During this time, she has also noted occasional blood on the toilet tissue after defecation. She has had she has not had constipation, abdominal pain, fever, nausea, vomiting. She has no history of serious illness. Her only medication is OCP. She does not smoke cigarettes or drink alcohol. She has had 3 lifetime sexual partners. She is married, monogamous relationship. Her last pap smear 2 years ago showed no abnormality. She worries that current symptoms may be affecting her performance at work. As an pharmaceutical representative, she maintains healthy diets. Abdominal examination, no abdominal. On rectal examination, there is tenderness, no masses are seen. Ready?
Yes. It's anal fissure. Anal fissures commonly present with rectal pain, particularly with defecation and bleeding because of a tear in anal tissue. Most commonly at the posterior midline. This tear is in the mucosa may expose the internal anal sphincter, may be associated with local skin type. Pain can occur from irritation of the tear itself or because of spasm of internal sphincter, the latter of which can cause ischemia and prevent healing. Causes of primary anal fissure include constipation, diarrhea, vaginal delivery, although secondary fissures can occur in the setting of systemic illness such as sarcoidosis, IBD, inflammatory bowel disease, HIV. The initial management of anal fissure includes the prevention or treatment of constipation, topical analgesics, and topical vasodilator. However, these methods are typically ineffective for chronic anal fissure, which are present for longer than like 2 months. Chronic fissures or those that are unresponsive to conservative management should undergo operative repair. In this scenario, in the absence of other systemic symptoms, the most likely diagnosis is anal fissure because of the timing of the patient's symptom with defecation, as well as blood in identified on toilet tissue. Okay, next.
A 47-year-old man comes to the physician for routine health maintenance examination, he reports no health programs. He has no history of serious illness, no medication, drinks alcohol, sedentary lifestyle, no family history, coronary disease. He is 5 feet 10 inch tall, 700 kg, BMI 25, temperature 36, pulse normal, respiration low, 10, blood pressure 120 by 70, cholesterol 200, HDL cholesterol, LDL cholesterol 137, and TG is 170. Which of the following most up? Ready?
One moment. Mm, mm, okay, ready. It is recommend exercise program. Cardiovascular disease, including coronary artery disease, is a major risk factor, is a major cause of mortality in the US. Risk factors for is development, obesity, tobacco use, diabetes, hypertension, hyperlipidemia, for diet, lack of exercise. Modifying this risk factor with lifestyle changes or medication can decrease the risk of coronary artery disease development. In general, if a patient's LDL cholesterol is below 190, the decision to start studying or HMA-CoA reductase inhibitor is based on the 10-year cardiovascular disease risk. In a patient with cardiovascular disease risk less than 5%, the risk of statin often outweigh the benefits. In contrast, if the cardiovascular risk is greater than 10, starting a statin is indicated. This patient's atherosclerotic cardiovascular disease score is 4.4, and his LDL concentration is less than 190. Therefore, he does not meet criteria for studying a cholesterol lowering medication. A better approach to initiating exercise program for lifestyle. Blah, blah. HMJ-CoA reductase inhibitor therapy or statin is indicated for the treatment of hyperlipidemia if LDL cholesterol exceeds 190. Or if the patient is increased risk for cardiovascular disease, this patient risk is 4.4. The statin is not indicated. I forgot how to calculate the ASCVD. Pardon.
Ready?
Next. Mhm.
Next. Hmm.
Do you remember how to calculate the ASCVD thingy?
Calculate
You see how they say that here is like if it's less than 5% or if it's blah blah blah.
more than
Remember how?
7.5% is significant. There is an app ASCVD calculates via there are a number of things you need to write ASCVD
Oh,
calculator, then you will find.
oh, okay. So here they just even if they didn't give
They
it to
will
us,
just told you that
they
estimated
will
one
tell.
is more than 7.5 or 10%.
Okay, here they didn't do. Okay, got it.
And for finding out this, you need to see the ASCVD calculator. There are plenty of things you need to uh,
Okay.
put there. Then you may got the answer. Okay.
Oh, no, this one.
A 24-year-old ALL, because of tingling sensation in his hands, feet for past 5 days. He also had nausea and vomiting. 3 weeks ago, 3 weeks ago he completed 2 week course of induction of the chemotherapy in breast and aspergine, dexamethasone, cyclophosphamide, cytarabine. On examination, cranial labs detected replace decreased bilateral sensation to drink and decrease on hands and feet. Which of the following is most likely? Okay, ready?
Okay. So it's vincristine is a vinca alkaloid medication that inhibits microtubule formation, thus arresting mitosis in cancerous cell. It's indicated for acute, like ALL, CML, and Hodgkin and non-Hodgkin lymphoma. Vincristine disrupts microtubule involved in axonal transport, leading to neuropathy in most patients who use it. Small sensory fibers are most commonly affected, though motor fibers are commonly affected as well. Common symptoms include paresthesia in the fingertips and feet, which may develop after weeks of use. Less commonly, symptoms include pain and mild distal weakness, for severe neuropathic symptoms, decreased dose or discontinuation may be necessary. It's not cytarabine, it's a pyrimidine analog that arrests DNA synthesis. It is typically used to treat leukemia. It may occasionally cause peripheral neuropathy, but not as common as vincristine. Okay.
Next.
Mhm.
I think this is a really old one because of 6 month history of increasing vaginal pain and itching. She has not had any pelvic pain or vaginal issues. Menopause occurred at the age of 51 years. She has no history of serious illness, takes no medication. A photograph of the vulva. Which of the following most likely diagnosis? Ready?
Yes. It is lichen sclerosus. Lichen sclerosus most commonly presents in patients who are postmenopausal with vulvar itching and pain associated with thinning and fibrosis of the genital and perianal skin. Other symptoms may include pain with sexual intercourse and lower urinary tract symptoms, such as dysuria and urinary urgency. Physical exam will show itch, pruritic white plaques, occasionally with ulceration in addition to the thin fibrous skin. Advanced disease can affect the anatomy of the vulva with narrowing of the ureters and loss of separation between labia majora and minora. Diagnosis is confirmed with biopsy. Lichen sclerosus is also associated with increased rate of squamous cell carcinoma of the vulva. Treatment is aimed at minimizing progression of disease and includes administration of topical steroids. Lichen planus is an uncommon inflammatory condition of the vulvar skin and vagina. Patients may present with vulvar soreness, intense pruritus, and burning. The erosiform may show narrowing of the introitus and loss of labia minora, similar to changes seen in advanced lichen sclerosus. Lichen planus typically affects the vagina, which is often not affected by lichen sclerosus. Okay. Additionally, lichen planus is significantly less common than lichen sclerosus. Okay. Next.
30-year old woman comes to the office for a health maintenance examination. She has had occasional shortness of breath during the past year, but is otherwise healthy. She has no history of major medical illness, takes no medication. She is concerned because her father and the paternal second cousin has alpha-1 antitrypsin deficiency. She would like to know if she is at risk for developing the disease. Vital signs are within normal limits. Examination shows no abnormality. Which of the following? Most appropriate next step in the diagnosis. Mm, Ready?
Yes. Is acquired patient consent for genetic testing. Alpha-1 antitrypsin deficiency results in the early development of panacinal emphysema and liver disease. It's hereditary disease resulting from deleterious mutation in the SERPINA1, um, which is located in the long arm of chromosome 14 and encodes alpha-1 antitrypsin. The mutation is inherited in autosomal codominant fashion. Alpha-1 antitrypsin is a protease inhibitor that decreases the activity of various proteases like neutrophil elastase. Defective alpha-1 antitrypsin function results in increased proteolytic degradation of alveolar septate in the lung parenchyma, resulting in panacinal emphysema. Panacinal emphysema is characterized by emphysematous destructive changes of pulmonary alveolar tissue, beginning in bilateral lung bases, resulting in bolus changes in the lungs, with the potential to spread diffusely. Hepatic damage occur via a different mechanism and result from accumulation of misfolded alpha-1 antitrypsin within hepatocyte. This results in hepatocyte injury and progression to cirrhosis at a young age. In patients with alpha-1 antitrypsin deficiency, development of both cirrhosis and panacinal emphysema can occur without significant additional risk factor for each disease. Patients with subsequent alpha-1 antitrypsin deficiency undergo genetic testing, which may show a causative mutation suspected. Those with a family history may undergo genetic testing in order to determine the risk for developing the disease. Affected patients may benefit from genetic counseling to determine reproductive risk. It's not C. Obtain chest X-ray of the patient is necessary. Chest X-ray is not a sensitive diagnostic for the patients with alpha-1 deficiency, particularly those with mild symptoms. Chest X-ray in affected patients may show abnormal areas of hypoglycemia. These patients with no symptoms is unlikely to have significant abnormal findings. Genetic testing is more tricky. Other serum testing AST and ALT activities of the patient is unlikely to be helpful, while serum transaminase may increase as a result of hepatocellular damage in patients with alpha-1 deficiency, and abnormal transaminase is neither sensitive nor specific and not helpful for confirming the diagnosis. Given this patient minimal symptoms, AST and ALT would likely be normal.
Next. 72-year-old man comes to the office 1 month after he sustained a middle cerebral artery infarction. Left MCA infarction. He was discharged from inpatient rehabilitation. He was discharged from inpatient rehabilitation 1 week ago. On discharge pulse, he was 92 and regular blood pressure 145 by 88. Lab studies during hospitalization showed hemoglobin A1C 57, cholesterol 180, HDL 45, LDL 105, ECG show atrial fibrillation, transthoracic cardiography show left ventricular inferior hypokinesis with ejection fraction 50%. MR angiography showed internal carotid artery stenosis 50% on the left and 50% on the right. 50% on the left and 50% on the right. Her medications are apixaban, atorvastatin, metoprolol. Which of the following is the most appropriate next step in evaluation to decrease the risk of recurrent stroke? Ready?
One moment. Abdomen. Yes. Already. It's measurement of BP. Cerebrovascular accidents, cerebral infarcts, and strokes occur as a result of ischemic or hemorrhagic loss of blood supply to the brain. Approximately 80% of strokes are ischemic, commonly arising from thromboembolic disease like Meadows, MCA occlusion from thrombus, whereas 15% of stroke are hemorrhagic due to blood vessel rupture from hypertension. Yeah. Basically, stroke will manifest as neurologic deficit related to the affected part of the brain. These factors for stroke um, for stroke include smoking, hypertension, diabetes, carotid or intracranial atherosclerotic disease, history of hypercoagulability, AFib, advanced age. Hypertension is the strongest modifiable risk factor, and age is the strongest non-modifiable risk factor. For every decade after 55, patient stroke risk is doubles. Stroke prevention strategies include stop smoking, regular aerobic exercise, reduction of BP, and reduction of cholesterol. It is not Measurement of PT and INR can be used to monitor patients' response to anticoagulation. However, these values are used when the patient is anticoagulated with warfarin. This patient is currently taking apixaban, a factor Xa inhibitor, which does not need monitor and also will not alter PT, and is not as it does not act on the intrinsic pathway. Okay. Wait. Carotid ultrasound is not necessary in this patient to decrease his risk of recurrence. So the patient already had a Doppler of his carotid artery showing 50% stenosis and 55% stenosis non-wide. Neither of these values require intervention repeatedly. Okay, next.
A 20, a 23-year-old woman comes to the emergency department because of 5-day history of red wound that leaks pus on her inner arm, that leaks pus on her inner arm. She also has 1 month history of mild headache. Her only medication is ibuprofen. She uses IV heroin, smokes marijuana. She has been sexually active with 10 male partners during the past 2 months, and her partners have not used condoms. Yeah, her temperature is 38 degrees Celsius. Pulse is 100 per minute, respiration 22 per minute, blood pressure 110 by 70. Cardiopulmonary examination showed no abnormality. There is 3 into 3 cm erythromatous, tender fluctuation, subcutaneous mass over left antecubital fossa. Her hemoglobin is 10.8, hematocrit 32, leukocyte 700. Segmented negative, 60% segmented negative, 20% bad, 20% leukocyte. Each of the following is the most likely cause of this patient symptoms.
Ready?
Yes,
HIV infection. HIV infection is most likely cause of the lab findings in this patient with high risk sexual behavior and IV drug use. The presentation of primary HIV can vary significantly between patients. Some may experience only a mild febrile illness, while others experience severe, like mononucleosis, uh, syndrome with fever, headache, sore throat, myalgia, diarrhea, lymphadenopathy rash. The time between infection and onset of symptom is variable, with incubation lasting several weeks or more. During acute infection, there is a high degree of viral replication, followed by widespread infection of CD4 T cells. While the T lymphocyte count may drop transiently, it's often normal in early HIV unless patients present with signs of opportunistic infection. Initial lab evaluation includes the use of fourth-generation HIV tests, which test for HIV P24 antigen and antibodies, combined with direct measurement of HIV viral load using reverse transcription PCR. It is most common in early infection for patients who have negative fourth generation tests with a high viral load. This is known as the window period. Once the diagnosis is made, lab samples should be sent for mutational analysis and genotyping, but this should not delay the immediate institution of treatment with antiretroviral therapy. Therapy typically includes a combination of at least three different drugs from at least two different antiretroviral classes. Next.
Next. One day after undergoing resection of the craniopharyngeal corridor, woman has confusion, lethargy, increased thirst, urination. She has no history of serious illness. Her only medication is morphine. She does not smoke cigarette, drink alcohol, or illicit drug. Her temperature normal, pulse 80, respiration 14, blood pressure 130 by 80. On neurological examination, the patient is alert, oriented to pursue, and place not to date. Speech is slowed. The remainder of the examination should go above. Serum studies show sodium 158, potassium 3.1, chloride 125, bicarbonate 22, creatinine 1.1. Hypernatremia, hypokalemia, hyperchloremia.
Visa restriction. Uh, Increased thirst. Ready?
Yes,
Um, Desmopressin therapy. Um, Desmopressin therapy is the most appropriate next step in management of this patient with central DI. Central DI may result from head trauma or surgery, as in this case. It is characterized by inadequate ADH secretion, vasopressin from the posterior pituitary. ADH typically binds to vito receptors in the DCP and the collecting tubule, which result in insertion of aquaporin channels in the luminal surface. This results in increased free water absorption and is typically used to maintain tight regulation of serum osmolality. Inadequate production of ADH by the posterior pituitary, like central DI, may occur in the setting of various pathologies such as pituitary tumors, trauma, tuberculosis. Intracranial surgery, this results in decreased concentration of aquaporin channel inserted within the principal cells of the collecting tubule, leading to inability to absorb the adequate amount of free water, which results in dilute urine and increased serum osmolarity. Diabetes insipidus can also be peripheral cause, such as lack of response to ADH by the kidney tubular cell. Patients typically present with production of large volumes of dilute urine, hypernatremia, and altered mental status. Treatment of central DI is with desmopressin therapy, an analog of ADH, which results in Recovery of free water via aquaporin insertion in the collective tube. It's not SAR restriction, it's the treatment of choice for a patient with peripheral DI. In patients with peripheral DI, the kidney tubes do not respond to ADH, resulting in excess free water loss. This creates hypernatremia that can be corrected with SAR restriction. In this patient with recent intracranial surgery, central DI is more likely, making SAR restriction incorrect. Okay. Next.
Yes. 6 hours after undergoing uncomplicated cardiac endarterectomy, a 77-year-old man with hypertension repeats left shoulder pain, difficulty breathing. He was admitted to the hospital 1 year ago for CHF. Temperature is 37 degrees Celsius, pulse 90 per minute, irregular respiration 18 per minute, blood pressure 120 by 70, pulse oximeter 2 liter of oxygen by nasal canal of a oxygen saturation 92%. The surgical site is clean and dry and intratrachals are hard on the lung base, heart sounds are normal. An ECG is shown which of the following is the most likely diagnosis.
Failure, shoulder pain, hip of the brain. If they have crackles ahead at the left lung base on the already.
Yes.
Wait, let me check. Is it ST elevation?
No, there is
Uh,
a state depression.
oh, that's depression. That's not elevation. Okay, then.
But the
I guess.
wait. The, okay, read the explanation.
Oh, it was that.
They are talking about, but there is
This
clinical ST depression.
this patient with left shoulder pain, shortness of breath, and ECG showing significant ST depression in the anterior and lateral leads has presentation consistent with acute MI. Patients with ACS, acute coronary syndrome, classically present with substernal chest pressure that may radiate to the jaw, yeah, neck of left upper extremity with associated dyspnea, nausea, and diaphoresis. Risk factors for ACS include advanced age, a history of hypertension, hyperlipidemia, diabetes, and smoking. If ACS is suspected, an ECG should be obtained immediately. The presence of ST elevation greater than 1 millimeter in two or more consecutive leads um, confirms the diagnosis of STEMI, and the patient should be taken for coronary revascularization as quick as possible. Patients with non-STEMI, with NSTEMI, may have ST segment depression, T wave inversion, or even unchanged ECG, but will have increased serum troponin concentration. The presence of significant ST depression in the anterior lead, as in this patient, could also indicate the presence of a posterior STEMI. Posterior ECG should be done to evaluate for this condition. Management of ACS includes administration of anticoagulation, antiplatelet agent, pain medication, and cardiac catheterization for risk vascularization. It's not congestive heart failure. Uh, Congestive heart failure when they compensate classically present with dyspnea, autopnea, bilateral fractures, venous distension, peripheral edema. Chest image of pleural effusions and signs of central vascular congestion. This patient has significant ST depression and ECG, which will not be seen in congestive heart failure. It's not this dissecting aortic aneurysm classically present with during chest pain that radiates to the back and hypertension. Patients may present with non-specific ECG changes in an ascending dissection. This patient ST depression in anterior and lateral leads are more consistent with ACS. Next.
One day after undergoing elective total hip replacement, hospital, a 75-year-old woman is somnolent and has slow, shallow breathing. She has had severe post-operative pain and has been receiving IV morphine. She has hypertension, GERD. Her other medications are amlodipine, omeprazole, enoxaparin. Medication, temperature normal, respiration 8, blood pressure 110/62, pulse oximeter, oxygen saturation is 88%. Examination shows clean, dry surgical incision without drainage, erythema. Cardiopulmonary examination shows no abnormality, there is no edema. Lower extremity neurologic examination shows no focal finding. Which of the following is the most appropriate next step in the management? Okay, ready?
Yeah,
Let's see.
is administration of naloxone. This patient is presenting with respiratory depression due to opioid, which are CNS depression used as analgesics and recreational. The opioids act through the CNS and uh, peripheral nervous system and interact with several neurotransmitter systems, leading to diverse effects. Opioid intoxication causes euphoria due to interaction with dopamine. Metastatic sedation in severe cases manifesting a decreased Glasgow coma scale score, and evidence by this patient decreased purpose for movement, bradycardia, hypotension, decreased respiratory time, meiosis. Meiosis is a distinctive finding that is less common in other neurologic complication in other neurologic condition and is caused by direct opioid receptor activity in brain areas responsible for pupillary control. Opioids also act on receptors within the enteric nervous system, reducing gut motility and thus causing constipation. Treatment of respiratory depression due to acute opioid intoxication requires naloxone. Short-acting opioid antagonists to prevent further respiratory collapse.
Okay. A 34-year-old woman, gravida 3, para 2, 36 weeks of gestation, comes to the office for first prenatal visit. She has received no prenatal care because she did not have health insurance until recently. After her last pregnancy 2 years ago, she was diagnosed with hypertension, which has been controlled with lisinopril since that time. She has no other medication, has no allergies. Blood pressure 130, where the patient is greatest risk of each of the pregnancy complication. Ready?
One moment. Between A and E. Genital heart block.
Why A? There is no bleeding.
I thought hypertension was one of the risk factors for, but she
Hypertension
doesn't really. But
risk
she doesn't really.
for PE, preeclampsia, isn't it?
for for pre-eclampsia. Okay, okay. And I guess it's E. Okay, let's see. It's oligodamia. This patient is at greater risk for oligodamia, which describes an inadequate amount of amniotic fluid or low amniotic fluid index. The reduced amniotic fluid volume leads to impaired lung development in the fetus, physical deformities or growth restriction of the newborn as a result of amniotic sac constriction, and umbilical cord compression leading to variable deceleration in fetal heart rate monitoring. While an oligoandanius can result from pre-labor rupture of membrane, fetal infection, post-term pregnancy, changes in maternal fetal circulation that lead to total placenta insufficiency, and congenital malformations of the fetal GU tract. It can also occur as a result of teratogens such as maternal use of ACE inhibitors. Oh, she uses ACE inhibitor. Lisinopril is a first-line medication for the treatment of hypertension, but it's typically avoided in pregnancy patients as it can cause fetal hypotension with subsequent kidney injury and oligoanuria. As amniotic fluid is largely composed of fetal urine, anuria of the fetus leads to oligoamdanius and is known um, sequela. Therefore, this patient who has had her hypertension treated with lisinopril during pregnancy is most at risk of oligoamdanius due to lisinopril effect on fetal kidney. Didn't know that. Next.
Okay. A 72-year-old woman comes to the physician because of 6-week history of intermittent rectal pain. With bowel movement, she underwent hysterectomy at the age of 42 years. For pneumoma uteri, she has hypertension treated with amlodipine. Rectal examination shows severe external hemorrhoids. Her hematocrit is 31. Which of the following is the most appropriate next in the match?
6 week history of terminal hematocrit. Wait, what's the hematocrit? Slow. Slow. Mm,
Ready?
one moment. See. Yes, ready. So it is colonoscopy. Several causes for lower GI bleeding, such as internal external hemorrhoids, anaphyseal diverticulosis, angiodysphagia, polyps, malignancy, AV malformations. Many of these causes are possible in a patient of advanced age, and the goal of evaluation is to determine the source of bleeding and treat it as indicated. Unexplained anemia in older patients is often caused by blood loss as a resultant iron deficiency, with the GI tract being a common source of occult blood loss. While bleeding in this case may be attributable to hemorrhoids, proximal lesion may also be considered, and colonoscopy, a means of both diagnosis and treatment, is the best next step in management. This allows for the direct visualization of possible lesions in the colon that may be caused by lower GI bleeding, and if indicated, treatment may be performed at the same time at the time of cause, such as polypectomy, biopsy, and cauterization. Angiography may be performed subsequently if the bleeding source is not identified or controlled with colonoscopy. Additional means of evaluation include capsule endoscopy, esophageal EGD, and nuclear medicine tag rectal scan. However, the most practical and useful initial is colonoscopy. Next.
Okay, we are done
Okay,
for
perfect.